Good afternoon, everybody. This is Michel Corbin from Mayo Clinic at ACC 17. I'm joined by Dr. Pieter Smits from Rotterdam, the Netherlands today. Good afternoon, Dr. Smits.
Good afternoon, Michael. I'm happy to be here.
Well, we are glad to have you with us. We're going to be talking today about the late-breaking clinical trial that Dr. Smits presented this morning, which is the COMPARE-ACUTE trial, looking at FFR-guided revascularization in ST elevation MI patients. Dr. Smits, can you give us a little bit of a summary of that trial and the results of that trial?
Of course. Well, the COMPARE-ACUTE is a randomized controlled trial, multi-center, specifically looking at STEMI patients with multivessel disease, and we did a strategy comparison. We looked at the multivessel, FFR-guided multivessel complete revascularization versus infarct artery-only treatment in 885 multivessel STEMI patients. And we specifically looked at the primary endpoint, which was a composite of all-cause deaths, recurrent myocardial infarction, recurrent revascularization, and cerebrovascular event at 12 months. Well, the outcome was at 12 months highly significant, superior for the FFR-guided complete revascularization arm compared to the infarct artery-only arm. And this result was mainly driven by revascularization.
Great. So what do you think is the cause for that? I mean, the significant reduction in the primary outcome, as you said, was primarily driven by the revascularization. Is this related to the number of patients in the trial? Do you think that we had a non-significant but a trend towards a decrease in cardiac events in the trial or not in the multivessel population?
Yeah, good question. Indeed, we saw a trend towards a decreased rate of hard endpoints like myocardial infarction. In fact, the myocardial infarction rate in the FFR complete revascularization group was half of that compared to the infarct artery only group at 12 months. If I recall, 2.4 versus 4.8%, but not reaching statistical significance, a p-value of 0.1. Indeed, I believe that the study was not powered for an individual components like hard endpoints like myocardial infarction or death. Therefore, this study was, I believe, underpowered. It was powered for a composite endpoint, and that was reached. Unfortunately, not for these hard endpoints.
Okay, great. Moving forward, what do you think is the next step? What is the next step or next study or trial that should be conducted in order to further answer that question, whether the multivessel revascularization guided by FFR or just the infarct-related artery revascularization is the way to go in the future?
Okay, yeah, I believe first of all, I guess what we should do next is a meta-analysis of the COMPARE-ACUTE trial and the NANAMI pre-multi trial, which looked also at the FFR guidance, but then again in a staged fashion. But if you can show by FFR guidance that you can also reach in a meta-analysis hard endpoint reduction, I think it's going. Then I think we're going to drive the guidelines even more towards a more aggressive approach than the conventional old approach that we have to only to treat the infarct artery only. So that's the first step, I believe. Second, I think we should also await other big trials like COMPETE and REVASC Full, which are 3,000 to 4,000 patients randomized, and specifically only looking at hard endpoints, the composite of death and myocardial infarction. That will potentially drive the field even more further. Yeah.
Great. Do you think that the results of the trial today should drive a change in the clinical practice at this point, or we need more data from the meta-analysis and the complete and the REVASC trial that you just mentioned?
Well, I believe that this trial at its own, together with the culprit and the primary trial and the dynamic trial, already showed that we should move back, you should move away from the conservative strategy in which you only treat the infarct artery only. I think it's undecisive yet whether you should treat all acutely or in stages. But if you do it stages, you should do it really early. And another item is, I believe that you should also look at the patient perspective and then at the economical perspective. From a patient perspective, it's better to have the patient is treated all in once, and that all the other lesions are investigated or interrogated on the spot. So it's a one-stop procedure for the patient. That's very very good, and he likes that much more than coming back to the cath lab. Also from an economical standpoint, I guess doing all in one is I believe economically more beneficial.
Great. Last question. Moving forward to a different trial that was presented at the same session this morning regarding IFR and FFR, what are your thoughts on this? I thought this trial was pretty good and the results are pretty convincing regarding IFR being non-inferior to FFR. Can you give us your perspective on that?
Yes, indeed. Those both trials were very convincing. Both reached a non-inferiority margin in a good fashion, and it's indeed showing promising from the IFR. Still, I believe I think the take-home message should be that bringing physiology into the cath lab is really important, and we should do it more and more. And whether it is FFR or IFR, I don't believe it will make that much difference. Only there's a small gray zone in which there's some discordant results where you have an IFR which is negative and an FFR is positive. Those, let's say 20% of the patients, I'm not sure how much that will influence outcome, and that's an uncertainty we don't know yet.
All right, great. Thank you so much for being with us, Dr. Smits. It was our pleasure. For more videos, please visit us on youtube.com/fitsonthego. Thank you.